You'll see a disclaimer on your screen for the recording, and we're going live in 3, 2, 1.
Okay, we'll go ahead and get started. I'm David Savitz. I'm a professor of epidemiology at Brown University and the chair of the committee that's addressing the Airborne Hazards and Open Burn Pit Registry. I have a few introductory comments, and then we'll go around and ask the rest of the committee to introduce themselves before we hear from our speakers today. First of all, just to remind you that we have a very well-defined scope and charge of reassessing the registry, the Airborne Hazards and Open Burn Pit Registry, and help provide to the Department of Veterans Affairs guidance on how to improve the data that's being collected, and including, we also consider other sources of data that may be useful for the same purposes and techniques for improving the registry. The full statement of task is available on the web page. And it's probably important to emphasize, given the ongoing and perhaps even renewed interest in potential health consequences from exposure to open burn pits, that we do not have the charge of making a comprehensive assessment of the potential health consequences, but rather a narrower charge to examine the registry and how it's doing and help see if we can find ways to help it be more effective. We're going to be hearing from 3 teams of experts today. First, we're going to hear from Dr. Mark Farfel, who's the director of the World Trade Center Health Registry, and he's going to be joined by Dr. James Cohn, the medical director of the registry, and Dr. Robert Brackbill, the research director of the registry. Then in the next session, we're going to hear from Dr. Rudy Bull and Dr. Ed Boyko regarding the Millennium cohort study of veterans. And then finally, the third presentation will be focusing on the use of the data from the registry from Dr. Nisha Jani and Dr. Michael Falvo of the VA's Airborne Hazards and Burn Pit Center of Excellence. If you have comments, those watching, and that would be potentially helpful to the committee or other information you want to share, it's best to send it to us electronically at the registry email address, which again is in the handout available online and also on the web page, so that we are certainly receptive to information. Given that we are still in the information gathering stage, that is, we're drawing in the knowledge and material and experience of others today, that will help us draw conclusions, meaning we have not drawn any conclusions. We will be asking questions of the speakers, and sometimes that can be interpreted as implying in some way that we have made judgments or reached closure, and that is not the case. We're just trying to do the best job we can to draw information that will be helpful to us. We anticipate a draft report around September of 2022, which will be thoroughly reviewed by experts and that we will respond to before it is released and finalized by the National Academies, by first the report review committee and then ultimately the president before it becomes official. So with that, let me ask the committee members to introduce themselves. We'll go in alphabetical order. John Balmes.
Hi, I'm a professor of medicine at UCSF and a professor of environmental sciences at UC Berkeley.
Thank you. Michelle Bell.
Hi, good afternoon. I'm a professor of environmental health at the university.
Thank you. Michael Daniels.
Hi, I'm chair of the Department of Statistics at the University of Florida.
Thank you. Marianthi.
Hello, everybody. Thank you. My name is Marianthi Kimurjoglu, and I'm assistant professor in Environmental Health Sciences Department of Columbia University's Millennium School of Public Health.
Thank you. Bramar.
Good afternoon, everyone. My name is Bramar Mukherjee. I'm a professor and chair of biostatistics at the University of Michigan School of Public Health.
Thank you. Fran.
Hello, everybody. I'm Fran Murphy. I'm a physician, neurologist, Air Force veteran, and president and CEO of Sigma Health Consulting.
Thank you. Kristen?
Hi, I'm Kristen Olson. I am professor of sociology and director of the Bureau of Sociological Research at the University of Nebraska-Lincoln.
Thanks. And Tyler?
Hi, everybody. I'm a statistician and epidemiologist.
Thank you. And let me also ask the Academy staff if they would introduce themselves, starting with Anne.
Hi, I'm Ann Stika, and I am the responsible staff officer from the National Academies.
Carrie?
Hi, I'm Carrie. I'm one of the staff members working on this project.
Michael?
Hello, I'm Michael Cohen, and I'm a statistician.
Thank you. And Alexandra?
Hi, I'm Alexandra McKay, and I'm a senior program assistant.
Okay, I think that I have done what needed to be done as a preliminary before we hear from the initial speakers regarding the World Trade Center Health Registry. And again, as I said, Mark Farfel, James Cohn, and Robert Brackbill, however you want to handle this part of the session.
Sure. Thank you, David. Good to see you. And wanted to thank you all for including us on the panel. So the three of us that are here today from the registry, we're going to address or attempt to address all the questions that you sent to us via email, and we're going to do that in order, because I understand that was some priority ordering of those questions. And so I want to begin with the first question, and Robert Brackbill will discuss that. And it's basically how our data have been used to conduct epidemiologic studies to inform etiologic research. So Robert, are you there?
Robert, you're there, but you're muted. I see you, but I don't hear you.
Okay. Yeah, that's a very broad question, and you know, given the committee's expertise, I just wasn't sure how to answer it. But I'll just sort of give you kind of some basic things, I guess. So I mean, in terms of like the way the cohort was first established, the World Trade Center Health Registry was established as a exposure cohort, and we gathered 2 years after 9/11. We gathered interview data, self-report exposure, and also that was pertinent to the populations at risk that we identified, that would be important to include in the registry, including rescue recovery workers, residents, building occupants, and students and faculty in public schools in the area around the World Trade Center Health Registry. We set up very early on a scientific advisory committee that met in February 2002, and they were helpful in giving us advice about how to kind of design a registry in terms of it being a sort of a total census of these populations and not a sample, for instance. Different ways that we've tried to handle eligibility into the registry, and also about kind of sort of basic sort of thinking about it as a cohort. The health information too was also self-report, and we used at that time information from publications and community input and things of that nature as to what to focus on in terms of what health to ask about is primarily respiratory symptoms, that cough and things of that nature. But we also included a battery of questions on mental health issues, and we had used the scale, PTSD scale, and also we asked about psychological distress, Kessler the K6. And the early papers that the registry did, focused primarily on replicating and adding to the body of literature that was all, that was appearing at that time, on the 9/11 exposures that were really specific for each of these populations at risk, as I sort of mentioned earlier. And also, that things were observed clinically that were reported. And the papers were outcome and population specific. And we used, pretty much standard methods, looking at associations. That early papers were just based on the baseline, the first survey. And then as the registry continued on, we built in matching, for instance, to cancer registries, which Jim will talk about in a bit, and also vital records. We added hospitalization as another objective measure as well. And then we, as a longitudinal study, we continued collecting data over time through surveys, self-report surveys, and asked some same questions, so as to get longitudinal measures of like PTSD and also various health conditions. But then we're able to get into looking at doing survival analysis and having some temporal relationships that might suggest some causation type relationships. And then as we got into further data, we started to include more mediation and trajectory analysis in looking at trends of different things over time, such as post-traumatic stress disorder, and then including other variables that seem to turn out to be kind of important, like social integration and intervening trauma experience and treatment, things of that nature. Also, another important thing I can mention in this regard is that early on, we established the registry as a platform for external researchers, and we set up a mechanism for people to make proposals, for studies that they would, be interested in doing using registry data. Like an example, like the first study that actually was got approved by a committee was one that looked at evacuation from the towers, factors that related to safe evacuation from the towers. And that was a English researcher, who studied, evacuation from fires, that sort of thing, how people got out and what related to that. So I think it's sort of like, you can ask questions on specific things, but I think that pretty much completes, my summary of related to that question.
Thank you. One thing we didn't talk about is whether we want to take questions sort of after each of these sort of introductions, or if we want to wait until the end. I don't know, Mark.
I think I just to make sure we can get through. We thought to suggest just have us go through and then leave a chunk of time at the end. Also, Jim Cohn, I didn't see his name here, but he says that he either dialed in or got in through the link, but we don't see him. Could one of the staff members email Jim and see what the issue is?
I can do that right now. The attendee side.
Oh, there he is now. Okay, we see Jim. Good. Jim, the next topic is performing health surveillance or uncovering emerging conditions.
Yes, the purpose of the registry was really to develop a platform for longitudinal looks at the potential emerging conditions. These are things that were unpredictable at the beginning of the registry, but we knew might be concerns, and these are mostly things that would be kind of thought of as chronic conditions. These were surveyed, as Robert mentioned, in a series of self-reported surveys. We've gone through waves 1 through 5 so far. We just completed our 5th wave. And these surveys have had a list of kind of consistent specific symptoms and list of chronic health conditions that we've been adding to over the years. But it's been also a way of tracking whether there's something emerging that we aren't necessarily aware of, but we'd have to be looking for more in depth in the future. We've also done periodic matching, as Robert mentioned, to the mortality data, both from New York City Vital Records and National Death Index. This has been helpful because of course, death is the most pertinent health outcome that needs to be tracked over a long period of time. We also do periodic matching to 11 state cancer registries. These were selected because they were the locations of over 90% of our enrollees. And we do regular matching also to the hospitalization data from New York State, statewide planning and research cooperative system. It includes emergency department and hospitalizations. And we also do other more, I guess, anecdotal type collections of open-ended responses on the registry surveys. We get letters and emails from enrollees. They report conditions that they think we need to know about. That's been very helpful. They may call us. They may read our materials and say, you really need to look at this. So I think it's been a really important source of inspiration, if you will, for more in-depth studies. We also review the published literature and we've conducted case control studies, in-depth studies using medical record reviews. We've done several studies looking at sarcoidosis, most recently systemic autoimmune disease. We also communicate with our colleagues at the World Trade Center Health Program, which is the program that's kind of the umbrella, including both the treatment and the maintenance or monitoring programs, as well as the registry. And we also collaborate on joint studies that have been funded for looking at cancer and mortality. We realize that our studies are limited in the sense we have 71,000 people, but it doesn't represent the whole population at risk. So we have pooled our data from the fire department in New York and also the groups of enrollees that have been in the treatment program. And we're working on incorporating also the residents. So we're, I think at this point, poised to be able to see if there's something emerging, something new that we didn't necessarily anticipate in the beginning of the registry. Shall I go on to the next question?
Please.
We also realized that the registry is a valuable source of information about people who actually need healthcare, medical care. There was an issue that came up in 2008. The Commissioner of Health, Tom Frieden, recognized that we need to do more than just count the numbers of people that have symptoms, but we should do something about what they're reporting. And he started by encouraging us to take on smoking cessation, recognizing that a lot of the exposures had a potential effect on the lungs. And we then began with looking at our program to actually do personalized outreach to help smoking cessation in our cohort. We then later developed something we call the treatment referral program, which once the World Trade Center Health Program was established as a coordinated treatment program, we wanted to refer people who reported symptoms that could be related to World Trade Center exposure to a group that can actually do the monitoring and treatment. So this is a group that does that personalized outreach to enrollees who report 9/11 related symptoms or conditions. We help them to apply for the Federal World Trade Center Health Program for the monitoring and treatment at no cost to them. We help them through the whole process, partly by providing reports on their survey responses. We've provided over 11,000 reports, help them document exposure eligibility for both the World Trade Center Health Program and the Victims' Compensation Fund, which provides compensation. We have dedicated staff. We've had nurses, social workers, and others with specific outreach backgrounds, trained in motivational interviewing techniques, which we can then use to overcome some of the barriers to applying. We've had over 7,000 enrollees contacted by our treatment and referral program who may not have applied otherwise, and they have submitted applications and are receiving care from the World Trade Center Health Program. We also have published several publications about how this treatment referral program is a model for how post-disaster registries can contribute themselves to long-term interventions. We've done health promotion activities. We've done emergency preparedness intervention study. We developed physician guidelines, which we're currently working with NIOSH to update. We develop health materials on topics of enrollee interest, and we disseminate our findings through our website, brief videos, periodic e-newsletters, and presentations at meetings with the community. Altogether, these activities are a key component of the registry that shows this is a registry that cares and contributes to long-term enrollee engagement. Thank you.
Thanks, Jim. Okay, let's move on. The next question related to how we support outreach and facilitate communications with sponsors, participants, stakeholders, community. And we're asked to just specifically discuss the work of our dedicated public affairs group. So Dr. Cohn just mentioned how the registry data do support health promotion and treatment referral outreach activities, but we also use our data to facilitate communications. First with the sponsor, we kind of in a mode of continuous reporting of our findings to the sponsor through progress reports, plans, through monthly research coordination meetings with NIOSH. We participate in their semi-annual principal investigator meetings that are attended by principals of the other WTC cohorts. When asked, we present to the Scientific Technical Advisory Committee of the World Trade Center Health Program that was established under the Zadroga Act. And we are in a continuous process of providing the NIOSH leadership with copies of our publications and presentations. And with regard to other stakeholders, we, as Robert Bracco had said, we have established and we do maintain working relationships with community labor and scientific advisors. We've held regular meetings to share our findings, to share our plans, to get their input on our content of our surveys and nested studies. And in past years, we held annual meetings to which we invited all 70,000 enrollees. We have a public affairs and panel maintenance cores, and both of those cores perform enrollee communications. So first, with regard to the panel maintenance unit, that unit handles all of the individual communications to and from our enrollees, and they conduct the ongoing tracing and locating of enrollees so that we can maintain an updated contact information. And they use the LexisNexis tools for that. And those are, among other things, key tasks that they perform. Now, we were asked specifically to give additional information on our public affairs core. So that core is responsible for communications with our community advisors, developing and implementing our communication strategies and plans with the enrollees, the public, and the media. And public affairs unit develops the e-newsletters, our testimonial videos with enrollees, research related videos, and the health materials that are disseminated, as Jim Cohn mentioned, through our website, mail, email, and social media. Our e-newsletters that have been successful in more recent years do include findings, resources about 9/11 and now COVID-related resources, enrollee stories, and links to the health materials and brief testimonial and research videos. The dedicated public affairs unit also conducts quality improvement focus groups with different groups of our enrollees by age and by preferred language. And we apply what we learn to reshaping our materials. We also monitor the website trends, our visitors, the video views, the dwell time, what most popular pages and downloads, and visits to the health materials. And as a general matter, the public affairs unit thinks about applying an equity lens to keep our diverse cohort of enrollees engaged. And they also reach out to other longitudinal cohorts to learn about best practices for enrollee engagement. And lastly, we do provide on the website our survey instruments, public use data resources, including de-identified data and data file users manuals. And I think both of those units with their communication functions do impact the quality of the data of our registry by keeping enrollees and their families informed about 9/11 related health outcomes and resources, and by keeping the enrollees engaged for the long-term participation in the research that Robert and Jim mentioned. We also contribute to policy and decision-making and processes. We do aim to inform healthcare for 9/11 exposed people, including care that's provided by the Federal World Trade Center Health Program. And that's both to responders and non-responder survivors through, for example, a focus on gaps in care, emerging conditions, and identifying research needs. And we also aim to inform future disaster preparation and response. The registry's work contributes to the science for certifying 9/11 related conditions by the health program through the peer-reviewed publications and the sharing of our findings at the World Trade Center Health Program, scientific meetings, and other scientific meetings and conferences. We also are engaged in contributing to 9/11 related policy and processes through interactions with policymakers and stakeholders. And I'll just give a few examples. We do provide testimony at city council hearings. We served on the mayor's 9/11 medical monitoring working group for 9/11. We do participate in the NIOSH World Trade Center Health Program responder and survivor steering committee meetings that meet monthly, and that promotes interaction with labor and community members who are there. And we do provide information to other city and state agencies, for example, that might be developing processes and policies to facilitate city employee access to 9/11 care and compensation. And also to inform NIOSH's health program decision-making, we conducted at the request of NIOSH a feasibility study of developing a new child cohort of people who are exposed to 9/11 as children. And this initiative was in response to community interest in having a new cohort for expanded research on people exposed as children. And then as one of the largest and one of the longest running post-disaster registries in the US, we do inform development and operation of other registries. And for example, there's a proposed bill in the New York State Legislature that would create a long-term COVID-19 registry. And it does mention the World Trade Center Health Registry as a potential model. And we've also been contacted over the years by other registries like Deepwater Horizon, the Flint, Michigan Lead Registry, and the South Korea ferry disaster, just to share our experiences and lessons learned. And finally here, we do contribute to occupational health and disaster science as well through publications on topics such as the health benefits of respiratory protection, hearing loss problems post 9/11, and high-rise building occupation. So the next question has to do with design or programmatic features that make the registry successful. And if you allow me, the three of us came up with a list of 9 factors that I wanted to mention briefly. And the first is the availability of long-term funding under the Zadroga Act that established the World Trade Center Health Program that includes a World Trade Center Health Registry entity. So while we do need to submit competitive renewals for funding, the legislation does specify that there shall be a World Trade Center Health Registry entity, and there is long-term support for the registry as well as the health program under the legislation. We also have a large diverse cohort of people exposed to 9/11, and that enables our research on 9/11 outcomes across a range of affected populations and subgroups. We also, at the outset, obtained enrollee consent to perform matching to external data sources. So that's the matching that Jim Cohn and Robert Brackville mentioned earlier, vital records, state cancer registries, hospital discharge data. And all of that activity is increasingly important as our cohort ages and attrition increases. We, as Robert Brackville mentioned, do serve as a platform for collaborative and independent external research. To date, we've approved some dozens of studies that as a whole extend the depth and breadth of registry research and has resulted in additional peer-reviewed publications and long-term collaborations for the registry. More focused internally, we have an in-house team of both master and doctoral level scientists with a range of backgrounds, as well as interns, medical residents, and epi scholars. And we are able, with our funding, to provide professional development opportunities for staff, including mentoring, presenting at conferences, and trainings. And 6, we have strong public affairs, panel maintenance, and also IT systems cores, including in-house capability for developing and processing web and paper surveys and tracing and locating our enrollees. And we've demonstrated an ability to turn on a dime to produce web and paper surveys following subsequent disasters such as Hurricane Sandy and COVID public health emergency. 7, the registry is based in a very large New York City Health Department. So that gives us access to a wealth of expertise in epidemiology, environmental health, mental health, vital statistics, and support from key agency shops like IT and communications. And we do have the established relationships now with labor, community, and scientific advisors, the health program, leadership, and the other WTC cohorts. And last but not least, we have the treatment referral project that was mentioned earlier, and we actively conduct other health promotion activities, all of which contributes to long-term engagement. So now I'd like to turn it over to Dr. Brackville to talk about challenges and limitations of our data.
Okay, well again. So I identified 4 different things that I considered sort of basic challenges, or I guess you use the term biggest challenges. I think the first thing is that this is a non-representative sample. I think I might have mentioned earlier that there was discussion when the registry was being designed in early discussions, whether it be a sample or whether it be a census, type of thing. And it really is, it comes up as census is really like a convenience sample to some extent. So the registry was actually built based on 2 different modes of recruitment. The one mode, which I think gives us a little bit more kind of credibility as to who's in the registry in the sense, or is that what we refer to as list-based recruitment. And there was a great deal of effort early on to get us to identify as many sources of lists as possible. Lists from unions, lists from agencies in the Department of Health, lists from we actually got a database of people who were occupants of buildings, based on credentialing, getting badges to go in the building. So we got as many lists as we could. And then those lists were then used to find people. And so thus we had some sense of what the original denominator was. And then there was a major effort, what we referred to as getting people to enroll through a self-identification. And that was where we used the media and handing out brochures and, used as many possible avenues for getting people to know about enrollment, and then provide an 800 number that they would call, and then they would, self-identify, and then if they were eligible for the registry, then an interview would follow, and then they would, so the bias is, in a sense, is that we have, we have a list where we can sort of say that there wasn't a bias in who was, contacted to be in the registry, but those, of course, people were self-identified. There might have been, various certain selection bias, obviously, for volunteering, in that way. The overall coverage was about 17%. And this is another issue, I think, with the registry, is determining what the denominators are, for the different populations at risk, such as respiratory recovery workers. We used various sources, and it came up with, that there are around 90,000 respiratory recovery workers. And it's interesting that other entities, might have, estimated less, some have estimated more. The other, major group that was sort of is the people who are occupants of buildings, and also people who are passerbys on the street. We're referred to as passerbys. And we estimated, through data on commuting, for instance, that there were about 300,000 people who may have been in that area, between the time of the first planes hit the buildings and then up until about, noon that day. And that, through we had estimates of just how many people might have been in the building through, through a number of people who came through on a daily basis. And that was around, I think 60, I might be wrong about that, 60,000. And then, we had the students, and we also had the residents as well. But those numbers were a little more easily obtained, through census data. Okay. So the second thing I want to mention as a limitation of registry is the definition of exposure. So we relied almost entirely on self-report, as I mentioned earlier. Just the nature of the disaster and the measurements that were taken on different kind of exposures, there was very little measurement at the individual level. So we relied primarily on self-report, and we set up the baseline interview so that we asked separate exposure questions that were designed for the different populations. Like, for instance, respiratory recovery workers, we asked for what their date of arrival, number of days they worked, what their activities. People in the buildings, we asked about dust cloud or on the street, dust cloud exposure. And then we also asked about trauma and injury and other issues, of everybody who might have been there on 9/11. What I can say is that over the years, we have found that our measures of exposure and the associations are consistent with other studies that may have been based on self-report as well. Other cohorts, you might say. Another thing that comes up, of course, is that we had no non-exposure comparison group. There was an early decision not to have such a group. I think one issue was that we had a large range of outcomes to look at and trying to decide, what was the appropriate, controls population for different outcomes was somewhat of an issue. The registry over the years has used a continuum exposure, from those people who had no exposure or low exposure, in the sense that they were not in a dust cloud and left the area early on, versus, and also respiratory recovery workers who might arrive, later in 2002, or even later after, after the end of September. So, and the fourth problem is attrition. I think that is another question that follows up. I can talk about that in more detail, but certainly, from wave one, we have around 15,000 people who did wave one who have not, answered any surveys since then. We've had 4 follow-up surveys since wave one, and so about 22% have not answered any other question, have not participated in surveys. And of course, given every time we do a survey, from wave 2 on, we've put an enormous amount of effort in reaching people, send out, multiple reminders, multiple surveys. So people have been bombarded with hundreds of requests over the years to participate, but there seems to be this kind of group who just sort of are not interested any longer. And we also have to mention that there are about 38% who, at least over the first 4 waves, have been intermittent in the sense that they may have skipped one of the surveys. They skipped wave 2 and then wave 3, or skipped wave 2 and wave 3, did wave 4, etc. We have 39% that we have, referred to as sort of a longitudinal cohort, who completed at least the first 4 waves. So I think that sort of covers at least those 4 things I identified to discuss. Thank you.
Thank you, Robert. So I'm going to handle the next 3 items briefly. And, there's a question about the future. What does it look like? We're beginning our next 5-year cycle in July. And so we do plan to continue the matching that was described earlier, but also to expand data linkages to include the World Trade Center Health Program and other data sources such as Medicare, Medicaid, and potentially in the future, the regional health information organizations as well. We do plan to do additional survey follow-up with our enrollees, including the Wave 6 survey 2 or 3 years from now. And we have planned several nested and in-depth studies, including an aging and cognition study, a COVID-19 follow-up survey, and studies of potential emerging conditions. And we do plan to conduct an additional round of the treatment referral outreach based on the recently completed Wave 5 survey responses. And as has been the case in previous cycles, we anticipate following up on new threats and public health emergencies, disasters that may arise, and address new community and scientific issues that may arise. In terms of, you asked a great question here about an end state, and truthfully, we just have a few early thoughts to share, and it's certainly something that requires a lot more reflection and thought. But the end state could be an entity based on matching to external data sources, could be a platform for secondary analysis with an archive with a public use data set or data file users manuals associated with that. And lastly, could possibly be a multi-generational registry, if there were a scientific basis for that. And then there's a question here about development and annual maintenance costs. Just thought here I would say that the Zadroga Act does specify funding for the World Trade Center Health Registry, the funding level. But I think that to be a successful registry, we do need to devote resources to our public affairs core. We have 3 staff there, including a graphic designer. We have a panel maintenance unit with 5 or 6 staff, an IT systems core unit with 3 or 4 staff. And also we provide support to our division's administrative team. And then in addition to that, we have about 14 city research scientists in our 2 research units. And then other costs are what you might expect, consultants, contracts, travel, conferences, communications, and matching expenses. So I just wanted to pause here and ask the organizers, would you like us to address retention and follow-up, or would you like to take questions to ensure that we have time for questions?
Again, I mean, this is, again, we thank all the speakers for being so responsive to our questions, which obviously we planned and thought about. And so unless any of the other committee members want to speak up and object, I would say to continue, because rather than sort of, I'm sure there may be, if we have a few minutes for follow-up questions, that would be great, but we really tried to prioritize and get the key issues out there. So the retention and follow-up would be a good way to proceed.
All right, well, let's do that. Robert, that's really the last area here.
Yeah. So, yeah, regard to the first question is for baseline participants, what's completion rate of baseline, and then for each to follow. I guess most of my comments are going to be related to the baseline. I might need a little help. I forgot to go back and look at what our response rates for each of the surveys were, but I can give you a general idea of that. As I mentioned earlier, there's two routes to enrollment, and that there was a list enrollment, and then there was also the self-identified. So the list was of 200 lists, which is a database of lists, and of 200 entities. And our contractor, RTI International, actually spent an enormous amount of time gathering these lists together and cleaning them and trying to get the information in them. And one of the major tasks that was related to lists was referred to as tracing and locating. And that's an activity, where you have people going through, if you have names or any kind of information, trying to find people and then get contact information for them, such as telephone number, which we wanted their telephone number so we could call them and interview them. The overall, it's interesting, the tracing and locating, from these lists was actually rather high. It was around 84%. That is the percentage of people that they were able to get some information on that would provide contact was 84%. And then after they contacted those people, they succeeded in getting a hold of 60% of them, with that tracing locating information. So as you sort of move on down through, you find out that 50% of those people, 57% were eligible in a sense. Out of that 60%, 57% were eligible. It keeps getting smaller. But then the last thing is the cooperation rate, which was pretty high, around 90%. So all those you're thinking about building a registry, especially when you're going out to list, it isn't just one response rate. And overall, you consider, the different measures at the different stages of what you do in order to get people into the registry. And just to mention, for the self-identified, just by the fact that people are calling and identifying themselves, is around 97%. The eligibility rate was fairly high in that sense too, it was around 80% in that group. So, and then we also looked at, we have a report that's actually published paper, Murphy and myself and and several other people published paper in 2001 on the coverage of the registry. And we reported in that, for instance, that about 33% of rescue recovery workers, we estimated were in the registry out of the 91,000 I mentioned. And then we broke residents out into those people who were close to World Trade Center Health Registry, and it's about 37% of them, and those who are further away, about 15%. And then, it's a little bit more difficult when you're talking about occupants of buildings because the denominator is hard to determine, but we had around 70% we estimated in that group. So I think in the follow-up surveys, Mark, you might want to correct me, but as I recall, wave 2, I think we had somewhere around 68%, of those people eligible for the follow-up, from baseline. And then as with each follow-up survey, it dropped, I think the next one was around 62 to 64%. And then I think the fourth follow-up was around 60%. And then we changed our, for wave 5, we decided that those 15,000 people, had not participated in any surveys. And so we didn't include them in the frame for wave 5. And I believe our response rate for wave 5 was 71%, with not including non-participants in wave 1. So are there particular ways with large loss of follow-up? Well, yes. Our largest loss of follow-up was with wave 1, and that was about 22%, as I mentioned earlier, and it was most among residents. The resident group, for some, just to take an example here, if you were to look at for wave 1, the proportion of people in the different groups, you had about 33% of people in wave 1 were rescue recovery workers, And 30% were residents, 29% were building occupants or passerbys, and 7% were other. When we did wave two, the proportion of people, for residents dropped from the 30% in wave one to 18% in wave two. And then of course the other groups went up accordingly with that proportionately. But the major drop was with residents, and they continued to get a low proportion of each wave from that point on till we got to wave two and wave three or wave four, about 14% were residents who participated. And I think the biggest, of course, the biggest change was the reputation of residents. The residents is defined as people who live south of Canal Street in Lower Manhattan. We also have, people who younger, participated, did not participate in future surveys. And then, of course, I think fewer, more women continued to participate. So I also want to mention that, looking at, kind of important question is, among those who participated in at baseline, and if you look over time, those who participated in future surveys, what are major differences in some of the exposure measures and also with some of the health measures? And it didn't really, if you were to just take simple questions from wave one, like on whether they're in dust cloud, the proportion of people in wave one who said in dust cloud is around 49%. And then wave two, 50%, and then wave two or three is 52%. So it didn't change much. And also the proportion of people who said yes to asthma didn't change much either. It changed from 13.5% to 14%. The mean PCL score also stayed somewhat constant over time as well. That PCL is the post-traumatic, checklist, and that stayed somewhat constant. About you take 17. The PCL goes from 17 to 80, I believe, actually, and so the mean was 31 in wave one. And then in wave two is around the same. It didn't change much. So I think it's interesting that, I think more, we could certainly delve into more of this, but that the non-participants and participants were not much different in some of the key exposures and outcome measures that, we've used over time, which is, somewhat somewhat kind of reassuring. So I think you had another question here where issues were partially complete. If so, how were they dealt with? Just simply, we did get, of course, some proportion of people who completed, started a survey, but then finished and answered all the questions. And typically what we did was we would select a set of questions, and then if they answered 80% of these selected questions, or kind of key questions, then we considered them a complete survey. So, and certainly, anything else, that you need information on and how we did things, we could certainly tell you. Yeah.
Robert, I just wanted to add one more aspect of the retention issue, and that is that we had a few thousand people who were children under the age of 18 at the time of 9/11, and as they aged into adulthood and reached 18 years, our IRB asked us to reach out and contact them and speak to them to obtain consent for them to remain in the registry as adults. And it's not always easy to reach them, but over time, as we have reached people, it's about 93% of them have agreed to remain involved as adults. So that was a good sign that there's ongoing interest, because these folks were originally enrolled, of course, by their parents in the registry.
I think, again, we really very much appreciate your said very direct responsiveness to the questions, the long list of questions we'd raised. if there, I mean, we have to watch the time, but this was, I think, a really effective way to present the information. I also have to just say that your command of the details and of this is really quite remarkable. I suppose that you've had a few years to have it all under control, but it's it's a very, very impressively comprehensive in the issues that you're managing so effectively. So I think unless there's a very quick question, we've just got a few minutes from the committee, and I'm looking for any hands or burning questions. Otherwise, I think we will just proceed then to the next speakers. And again, to thank those who participated.
David?
Okay, there is one quick question.
No, it's not
John.
a question. I just want to give a shout out to my old friend, Jim Cohn. Person for a while.
Indeed. No, I have my own little bit of history. When I was at Mount Sinai, of a tangential involvement with the registry. We all cross paths sooner or later that way, I think. So, okay. Again, thank you very much, and we'll proceed then with the next session. We're going to be hearing on the Millennium Cohort study from Rudy Rule, who is the PI, and Ed Boyko, who, again, while we're going over past connections, Ed and I were members of the same academic department. It's almost unnerving to say it, but about 40 years ago. So I'm looking forward to hearing from Drs. Rule and Boyko about the Millennium Cohort study.
Thank you all. I'm just going to go ahead and get set up. I'll be presenting some slides along with Dr. Boyko. So let me get this running.
Okay,
and
thank you. Again, thanks for taking the time to speak to us today.
And share my screen. So let's. Oops. And I hope this is visible. Good afternoon, everybody. I'd like to just go ahead and start with the standard disclaimer and point out that this work is sponsored by both the Department of Defense and the Department of Veterans Affairs. Dr. Boyko and I really appreciate the opportunity to discuss the Millennium Cohort study. I can start with a general overview, discuss the survey data collection, exposures and respiratory outcomes, and future directions. Dr. Boyko will further describe the longstanding VA collaboration that's now culminated in a data sharing agreement that enables the linkage of VA data with Milco survey data and facilitates the sending of Milco data to the VA. And throughout the talk, we will also address questions provided to us from the committee. As a broad overview, the objective of the study is to prospectively determine the impacts of military deployments, experiences, and exposures on the long-term health of service members and veterans. And since launching in 2001, Milco has become the largest and longest running cohort study in military history, with over 240,000 service members enrolled who represent all services and components. This objective is operationalized as a multiple panel cohort study of service members from all services and components. And since 2001, there have been 4 separate enrollment panels between 2001 and 2011. And the 5th panel is currently being enrolled. So participants complete an online or paper survey every 3 to 5 years, even after they leave military service. And in order to effectively capture the life course of service members, follow-up of participants is planned through 2068, which is an extension of the initial 20-year study. The surveys are designed to assess participants' physical, mental, and behavioral health and include questions on military exposures and experiences such as combat and deployment. And then the context of survey burden, we do like to think of the survey instrument itself as broad, but not very deep. However, we are able to increase that depth by linking with multiple military and medical databases, and that now includes the VA, which Dr. Boyko will address later in the session. These data are then analyzed as part of an extensive portfolio of epidemiologic research. While deployment has been one main focus, interests also extended to military occupations and other experiences, such as physical and sexual trauma. This work has yielded over 120 publications to date, and in addition to published papers, dissemination of our findings has also taken multiple forms for different target audiences that include stakeholder summaries, infographics, and press releases in coordination with our command, newsletters targeted toward participants and research partners, and most recently, an annual report to Congress on the reproductive health of servicewomen. So within the DoD, we established knowledge transition agreements to establish partnerships with DoD stakeholders ranging from the Defense Suicide Prevention Office, Sexual Assault Prevention and Response Office, and the Special Operations Command. So while the study itself is not designed for health surveillance, there can be opportunities to examine emerging health concerns such as traumatic brain injuries. And this is what really motivated our prior work on burn pits and respiratory outcomes, that Dr. Smith on the panel was involved in addition to being a prior principal investigator. While study data itself is strictly used for research purposes and not for directly informing healthcare for enrolled participants, we recently published a paper on adverse mental health outcomes among Army veterinarians, where the findings were used to inform the development of a behavioral health program called VetFit. This timeline here illustrates the longitudinal and multiple panel design that are foundational to the success of the study. Follow-up surveys occur approximately every 3 years, with new enrollments of current service members every 6 years. So we are actively doing both as part of the 2019 to 21 survey cycle, where panel 1 is currently in their 6th wave of data collection, while we are recruiting and enrolling new participants for panel 5. So I'm just going to switch over and point out that this slide illustrates the provides characteristics of each of the enrollment panels, and you can see that panels 2 through 4, they really targeted the selection of participants who were earlier or who had less years of military service, along with targeted oversampling of women and certain underrepresented groups. And we are, as I mentioned, we are currently enrolling panel 5, and that's been the case since September of 2020. And we are looking to close that in August of 2021 with a, and currently we have about 44,000 participants who are enrolled in this study. Oops. Actually, if I could just have 1 minute, I would just realize I switched the order on the slide. So I'm just gonna switch my presentation. I apologize for the inconvenience. Okay. I'm sorry, please bear with me 1 minute. There was a switch in the order. Okay. So with respect to our enrollment rates, we have, I will note on this slide that we have been seeing a decrease in the percentage of contacted individuals who enroll in the study from a high of 36% for panel 1 to 20% for panel 4. So we are definitely seeing this decline in the current enrollment, where we have started with a roster size of about 500,000 participants and reached out, we'll say, with email, postcards, and letter invitations. Currently, we have enrolled about 44,000 service members, or just short of 9%. And we're hoping that we can really get to a target of 10% right now by the close of August. And with respect to the response rates for our follow-up surveys, participants from panels 1 have had the highest rates of response, from as high as 71% in the first 2 waves of follow-up, down to 51% in the current wave. For panels 2 to 4, there is a clear reduction in response, with 50 to 55% responding in their first follow-up survey. And for the current wave, the response is in the 30 to 35% range, and we are looking to increase that in the next 2 months with our weekly contacts through this August. So this slide here provides a glimpse of the first 4 panels of the cohort with respect to demographics and military service. And with oversampling and relatively higher response rates, almost a third of our participants are women, with 30% non-white, and most are from the enlisted pay grade and the active component. You can also see the distribution by branch, with about 45% coming from the Army. About 65% have ever deployed, and 3 out of 4 are no longer in military service. We also know that about 1.5%, or approximately 3,000, are deceased. Also, because panel 1 participants were selected regardless of their length of military service, their mean enrollment and current ages are over a decade older than those in panels 2 to 4. And since panel 5 is currently enrolling, we don't yet have a complete profile of these new participants. And from what we've seen so far, one difference we've observed is a lower than expected enrollment of Army personnel. Another contrast from previous panels is the increasing racial and ethnic diversity of participants. So our study team is also looking into patterns and profiles of attrition, and there are distinct groups that we are losing more than others. These are specifically younger males from junior pay grades and lower levels of educational attainment, racial and ethnic minorities, as well as those who never married. And with this loss of information on self-reported health outcomes over time, it does make it challenging, it does really make the ability to link with VA and DoD medical records much more critical to the success of the study to ascertain long-term health. So this slide here illustrates the numerous enterprise databases of healthcare utilization and diagnoses, deployment histories, immunizations, mortality, and other objective measures. And with respect to specific aspects of deployment histories, we are, like many other researchers, awaiting the availability of the ILR to characterize exposures defined by specific locations and proximity, as well as the absence of proximity to hazards such as burn pits. And as has been briefed in previous National Academies presentations, the only external data that we currently have to date on potential exposure to burn pits was from a limited data feed that was provided by DMDC that identified personnel deployed within 3 and 5 miles of 3 documented burn pits in Iraq between 2003 and 2008. This information on proximity covered about 22,300 deployed Army and Air Force participants enrolled in panels 1 to 2, of whom about 3,500 were deployed within 3 miles of one of these burn pit sites. Across the larger Milco population, historical exposure assessment is currently limited by the classified status of within country deployment locations. And so we currently rely on proxies such as country level deployments and the limited data feed from DMDC. And since that release, we haven't been able to get any new data. However, we do anticipate access to the ILR for research purposes that will include de-identified deployment locations and dates. With respect to tracking burn pit exposures in the survey, we have attempted to ascertain this as part of a 13-item screener on combat experiences among deployers, where we specifically ask about exposure to smoke from burning trash and/or feces. And for the survey item, we find that over half of the deployed participants across the 4 panels endorsed having more than one occurrence of exposure. With respect to respiratory health, participants in the survey are asked about physician diagnosed conditions, including sinusitis, asthma, chronic bronchitis, and emphysema. And in our current survey, we've added questions that ask about the frequency and severity of asthma symptoms. At baseline, participants are asked about ever having been diagnosed, while at follow-up, they are asked about diagnoses in the last 3 years. And in addition to these diagnosed conditions, participants at each survey are asked about persistent or recurring cough or shortness of breath. Dr. Boyko will also provide some additional information on these frequencies of these outcomes among veterans and comparisons with military and veteran medical records. So regarding our current and future research, we look to focus on the extended follow-up of health outcomes using surveys linked with MDR, VA, and mortality data. A unique aspect of the cohort is the availability of self-reported cigarette smoking data, and we have been examining this behavior as a potential effect modifier on deployment-related environmental exposures. We'll also look to focus on specific occupations based on self-reports and military occupational specialties. Once we close the current survey cycle and clean the data, we'll be able to look at the frequency and severity of asthma symptoms. And we've also started new analyses on all cause and cause-specific mortality in relation to deployments. And we'll look to focus on cancer as well, especially with most panel 1 participants now in middle age. The other important need for examining the effects of airborne hazards encountered during deployment will be the ability to access declassified deployment locations and dates that will be critical for historical exposure assessment and help us get beyond country level deployments and the limited proximity data for select sites provided by DMDC in 2010. So we're very excited by the coming availability of the ILR for research purposes, and in conjunction with specific deployment location and date information, we could potentially apply estimates of historical PM 2.5 concentrations generated using remotely sensed data that have been generated for the VA CSP 595 SHADE study, which is the Service and Health Among Deployed Veterans study. And I do want to add an additional note that didn't quite make it into the slide as I was looking to get these approved. But as I've noted, this we are currently in the 2019 to 21 survey cycle, and this is actually 2 years behind schedule due to regulatory challenges that delayed a survey launch planned for 2017. So, so this hopefully sheds some light on some of our regulatory barriers that we face as we put the study up. The approval process, specifically within DoD and the Office of Management and Budget, takes about 2 years. And so for a 2017 survey, we developed the survey and submitted it for review in 2015. That approval ultimately came 1 year late in 2018. And we further needed to ensure our data collection and storage server was in compliance with new requirements for securely collecting PII and PHI. And while we were able to bring the server into compliance and ensure that there was no collection and storage of PII and PHI going forward, this meant that we were not able to launch our follow-up survey until October of 2019. It took us some additional time to develop a solution for confirming the identities of newly enrolling participants, and we were ultimately able to launch the Panel 5 enrollment in September of 2020. And because our current OMB approval for data collection expires this August, the Panel 5 enrollment period is actually shortened to 11 months instead of the 18 to 24 months for previous panels. Another issue with respect to regulations is that as part of the survey approvals, we do need to reduce the amount of burden among participants. So as part of a DoD-wide initiative to reduce survey burden, we've had to reduce the length of the current survey such that the paper version of the survey that had typically been about 24 to 28 pages was reduced to 16. So at this point, I'm happy to turn the presentation over to Dr. Boyko, who can spend more time describing the VA linkage. Thank you.
All right, well, thank you, Rudy. I want to thank the National Academies for inviting me to give this presentation, and good to see you again, David.
Good to see you too, Ed. Thank you.
So on the VA side, the Millennium Cohort Studies, referred to as Cooperative Studies Program 505 Millennium Cohort Study. And the study was designed with the plan to follow up participants using VA healthcare data after separation from the military. So back when it was first being conceived in 1999, 2000, that was the plan, because we recognized at the time that the VA can provide objectively measured health outcomes and other information in addition to survey self-report. And in fact, the original IRB application included the plan to share data, which was approved. However, there were problems with VA data breaches in the 2000s. And so that delayed our progress towards this goal. But we did receive approval from both DoD and VA in late 2018 for bilateral Millennium Cohort participant data sharing between these two agencies. And the way it worked was identifiers were sent securely from Naval Health Research Center, which is where Dr. Rule is located, to VA Puget Sound for matching. And then Millennium Cohort participant identifiers were matched to VA care facility encounters nationally. So what was, how frequently did we find matches? Well, much more frequently than we expected. So as Rudy mentioned, most of the participants in the Millennium Cohort now are veterans. And so of the 147,000 or so participants who were veterans, about 92% we found registered in a VA facility, so almost 136,000. So I'll just show you about the number of care encounters they've had in the VA system. So what's shown here in this figure are the fiscal years on the x-axis, and on the left y-axis are the number of outpatient encounters. And the blue bars represent the number for that fiscal year. And you can see that in 2020, if it weren't for COVID, there probably would have been close to 1 million outpatient encounters among Millennium Cohort participants who are now veterans. And on the right y-axis are the number of unique patients, so the number of unique Millennium Cohort participants who are getting care in the VA system in that fiscal year. It looks like it was about 65,000 or so in 2019. And you see pretty much the same pattern for inpatient discharges. So again, fiscal year on the x-axis, number of discharges on the left y-axis. And you can see these peaked in 2019 and then fell due to COVID restrictions in 2020, mainly on elective hospitalizations and elective surgical procedures. So how often do Millennium Cohort participants newly enroll in VA? Well, we examined this. We looked at the new enrollment in the VA among these participants over a one-year period from March 2020 to March 2021. And there were 2,639 new enrollments, so that was about 51 per week. So what are our sources of medical encounter data? Well, on the DoD side, it's the Military Health System Data Repository, or the MDR, which includes information on active duty service members and activated reservists. Of course, we can access inpatient and outpatient ICD codes, CPT codes, pharmacy data, and also this allows access to all care paid for by TRICARE, both at military treatment and at private facilities. And then the VHA, the VA system, we've been able to access data ever since the data use agreement in 2018. So I'll just show you some information on agreement between the self-reported respiratory conditions that are found on the Millennium Cohort survey and VA and DoD medical records. So Rudy mentioned we asked about asthma, chronic bronchitis, emphysema, sinusitis. So on the top row, you can see that there were about 11,000 Millennium Cohort participants who self-reported asthma. And in VA records, we found almost 10,000 participants with a VA record that showed an asthma diagnostic code. And the positive agreement between self-report and VA records was almost 48%. The negative agreement was about 95%. If you look down at the other rows, the positive agreement is much poorer for chronic bronchitis and emphysema, and in the middle for sinusitis. So this just examines the association between self-report and VA records. And if you add in DoD records, or the MDR, you find that it actually doesn't change the situation very much. If you look at asthma, the agreement using both VA and MDR records for any occurrence of an asthma diagnosis, the positive agreement just increases from 48% to 50%. The negative agreement is slightly reduced, but not by very much. The positive agreement for sinusitis, the bottom row there, increases a lot, but at the expense of poor negative agreement, it falls from 86% to 75%. So there was interest in seeing what links existed between the Airborne Hazards Open Burn Pit Registry and Millennium Cohort study. And there were several individuals interested in this, from post-deployment health service at VA, Aaron Schneiderman and Eric Shuping, and also Rudy Rule was interested as well. So we performed, after getting the necessary approvals, we performed a linkage in February 2020, and we were provided with a burn pit finder file, which had about 194,000 rows. We excluded a few rows due to duplicate Social Security numbers or absent Social Security numbers. And the first row in the table is the number of Millennium Cohort study participants who were VA users who we found in the Airborne Hazards Open Burn Pit Registry, matched by Social Security numbers. So we found 10,042 matches. There were also 2,485 matches among Millennium Cohort study participants who were not VA users. And if you look at the right column where the matching is on multiple criteria, last name, first name, date of birth, in addition to SSN, the numbers reduce by about 25%, but just by Social Security number, there are about 12,500 matches, and this is over a year ago, so there are probably more matches since. So I'll just talk about mortality data sources. These come from several different sources. the National Death Index for cost-specific deaths, and this captures deaths in former and current service members, and the Defense Suicide Prevention Office provides this information. The Armed Forces Medical Examiner System provides information on deaths in active duty and activated reserve and National Guard, includes deaths occurring outside the continental US, and the source is the Armed Forces Health Surveillance Board, and then vital status files at the VA, which includes the Social Security Death Master File and other medical care and administrative files. So what will VA DoD data sharing accomplish? Well, the matching will provide information on service-connected conditions on the VA side, pharmacy prescription fills, laboratory results, other diagnostic and illness severity information, and the sharing will enable much better assessment of these outcomes in relation to military service. And also there are other impacts that will improve the ability to validate survey information obtained from Millennium Cohort study using objective VA data, as I've shown you an example of for respiratory conditions. It'll also expand the types of health outcomes we can identify in relation to military service beyond what is available in the Millennium Cohort survey that's conducted every 3 to 5 years. It'll also enhance the ability of Millennium Cohort study to assess long-term health effects in military service. And regarding future plans and possibilities, the Millennium Cohort study is planned to continue until 2068. So there's no end state in the foreseeable future for the study. We're considering biomarkers because on the VA side, the Million Veteran Program is actively gathering biomarker information. And there are also other VA biomarker repositories like the SHIELD repository, which contains biomarkers for not only COVID, but also infectious diseases. There are remote collection opportunities, saliva for DNA, and there's something called the TASO remote blood collection system. There are probably other systems as well. We're always discussing linkage with cancer registries, although that hasn't happened yet. And of course, we'll be considering collaborations with other research under planning or development. And I want to thank you for your attention.
Very good. Thanks to both Dr. Derzrul and Boyko. We're about out of time, but I think we should take maybe 5 minutes, partially because I have a question and then other committee members may as well. Let's say I recognize that the entire sort of structure is to look at a wide range of different possible military health impact. Would there be an opportunity, if you wanted to expand the recruitment? Let's say when you have EILER data, would you have the flexibility or adaptability to oversample, let's say, in certain historical military deployments or experiences? And obviously we're interested with respect to burn pits, but I could imagine there would be other issues as well, where there would be sectors of the military where you wanted more of them beyond the samples that you have. I just didn't know if that's something that's imaginable in the Millennium Cohort study.
It's something that we can consider. You know, I think the framework is that it's really current service members that we look to enroll initially, because we really want to establish that baseline for them within their service. So, you know, we haven't really ever tried to enroll, say, veterans who may have been exposed previously. But it's something that we do consider potential areas for oversampling. Most recently in our planning, we thought we would potentially oversample for special operators, for example, but it seemed that within our sampling frame, we would already have captured a substantial amount of those. So but it's something that is something that could be considered, say, within an occupational focus, for example.
Sure. Okay. Let me just see if the other committee members, again, we'll take another few minutes here. Questions that you would like to ask of regarding the Millennium Cohort. Any?
Sure, I'll jump in here.
Thank you, Tyler. Go ahead.
Hey, Ed, good to see you.
Good to see you,
Hey,
Tom.
Rudy. So obviously we've had some great discussions, and I know a lot about the foundation of the study, but it's just exciting to hear how much progress is being made with actually linking VA and DoD data. I think that, Ed, as you know, for 2 decades, we've been pushing that ever since Foisner said it would happen, and it's just great to see it. Where do you see that benefit showing up if you're looking at a registry study like what we were looking at here? How do you see those VA and DoD data benefiting, and what sort of research do you see Millennium Cohort offering that sort of data linkage to a registry like what we're looking at here?
Yeah. So we're early on in this process, and when you were involved, we were doing foundation papers, and so this survey validation analysis that I presented a glimpse of is going to be a foundation paper. But we also actually have 2 studies that are funded now to look at linked data. One, a study on Parkinson's disease, which will look at environmental exposures. That's funded by the Michael J. Fox Foundation. And another on melanoma risk factors, which is funded by CDMRP. So I think, and there's another application in process looking at eating disorders that plans to look at different VA health outcomes. So I think it's I think it's a gold mine, but unexplored mainly. So I think it'll create a lot of opportunities, and I think it's pretty much you name it, and we might be able to support the research.
Other quick questions from the committee, if any? Again, you've done a great job in responding to, obviously we were pretty clear about what we were interested in, and you did a nice job of responding to the issues that we had raised in advance. Any? Okay, I think unless anything comes up, again, let me thank you again for taking the time to talk to us, and said very impressive work you're doing.
All right.
Okay.
Thank you.
Very good. We'll continue next and third and final discussion with the folks from the VA Airborne Hazards and Burn Pit Center of Excellence, and Doctors Michael Falvo and Nisha Jani will be speaking to us, I believe, making a presentation, and then there will be some time for, I think, additional questions as well.
Thank you very much. And I'm going to start presenting now. Okay, good afternoon, and thank you for inviting Dr. Falvo and myself. I'm here to speak about the Airborne Hazards and Burn Pit Center of Excellence and our efforts associated with the Airborne Hazards and Open Burn Pit Registry. I would first like to state that we do not have anything to disclose, and the contents of this presentation do not represent the views of the U.S. Department of Veterans Affairs or the United States government. Here's a list of current funding support for the Center of Excellence. The Airborne Hazards and Burn Pit Center of Excellence was designated by Congress and the President in Public Law 115-929 as a VA Center of Excellence, VHA Directive 1215. We have 4 priority areas, which include activities related with the Airborne Hazards and Open Burn Pit Registry, specialized care, research, and the creation and dissemination of high quality education. Today, we will focus on the first priority. However, we'll be touching upon all since they do overlap across each of these areas. This information, this afternoon, the information we'll be providing will be on the airborne hazards clinical exam data, analysis of the self-reported registry questionnaire, overview of some recent research, the center's key collaborations, some active research, and also an overview of our future efforts. I would first like to briefly walk you through the registry to better understand the flow of the data, from signing up to completing the questionnaire and receiving the airborne hazards clinical examination. This is the registry homepage, where a veteran or an active duty service member goes as the first step in this process. Here, they can get journal information about the registry and read about the eligibility criteria. To proceed, they use their DS logon account to enter the system. This logon is a secure identity credential that veterans and active service members use across various sites. If the individual is deemed eligible based on their deployment history, they can proceed to complete the self-assessment questionnaire. The questionnaire captures information on exposure and health concerns, health history, activity limitations, and additional risk factors that may affect our service members' health. On the bottom of the screen, you'll see a clip from the healthcare utilization section of the questionnaire. There, you can see the question asking if a participant wishes to see a DoD or VA healthcare provider to discuss their health concerns related to airborne hazards during deployment. During this presentation, when I refer to participants who have noted interest in a clinical exam, I'm referring back to this question and who's someone who had an affirmative response. Once the questionnaire is completed, VA facilities have three primary ways to access the registry data to support the care of veterans: the provider portal, joint legacy viewer, and individual longitudinal exposure record data, which is the platform is referred to as EILR. The provider portal houses information on everyone enrolled in the registry. It has the capability to run operational reports and download summaries of participants. There are approximately 1,200 registered users of the provider portal. The process of retrieving registry data to support evaluations differ among care providers and facilities. In some settings, physician users might access the portal themselves. And often in others, reports might be pulled for the provider by other VA staff prior to a consult. EILR and JLV are newer functionalities where the questionnaire information can be obtained. JLV can be accessed through the medical records. And as for EILR, I know it has been discussed in the past. So, but however, this is another source of registry information. Next, we have the Airborne Hazards Clinical Exam. This is a screenshot of the standard clinical notes template, which is used across VA facilities. It can be accessed through the electronic medical record system by the provider. This tool allows for the uniform documentation of veteran health factors. Having a notes template specifically for airborne hazards helps in the analysis of this data, since we are able to search for specific notes titles. And while participants, and also when we're pulling information on participants who have received an exam. The most prevalent chief concerns documented during their airborne hazards exam are shortness of breath, gastrointestinal problems, chronic sinus infection, runny nose, and decreased exercise ability. There can be multiple health factors for each participant. As of June 1st, there were an average of 5.5 chief concerns among each participant who received their airborne hazard clinical exam. As of June 15th, 2021, there were 22,560 airborne hazard clinical exams done at the VA. Almost 3/4 of the participants who received an exam had also stated interest when completing the questionnaire. This refers back to the question which I had shown originally under the healthcare utilization section of the questionnaire. Almost all were eligible for VAJ care. There are exceptions, but in general, eligibility is based on the length of service and also the type of discharge. Among all eligible veterans participating in the registry, this is with and without airborne hazard examinations, 91% have been enrolled for VA care. The percentage of participants who have received an exam increases each month. The common template used by all facilities during the clinical exam aids in the consistency of data among sites nationally when documenting chief concerns and abnormalities. Also, the information being captured by healthcare providers, in this case, as opposed to being self-reported. Additionally, the exam provides an opportunity for the veteran to provide information which was not necessarily captured during the registry questionnaire. While there is relatively a small percentage of participants who have received the airborne hazard clinical exam, having the ability to match this data with VA medical records helps us gain more information regarding on medical diagnosis and also healthcare utilization. However, there remains to be challenges and limitations. This is a voluntary exam available to participants who have completed the Airborne Hazards and Open Burn Pit Registry questionnaire. This represents a subgroup of veterans who tend to have greater interest in airborne hazards and very likely have seen negative health effects post-deployment. This data can lead to important findings. However, it is difficult to be generalizable to the greater eligible population. We also have to rely on the utilization of the notes template and need to ensure that there's awareness across VA facilities that this notes template is available and should be used for this purpose. The notes template does capture some free text information, which can be challenging in order to analyze that data. Now we will shift to discuss the self-reported questionnaire data. There's currently almost 250,000 participants in the registry. A majority are male at 86% and are in the Army. The mean age is 43.3 years. We do routine analysis of the questionnaire data, which includes weekly summary reports, monthly review of the clinical data, and additionally, operational analysis is performed regularly based on ad hoc requests from stakeholders. We have been doing monthly surveillance of COVID-19 data since April of 2020, reviewing the testing and incidence amongst registry participants who use VHA care. As of June 1st, there had been 5,767 participants with positive testing for COVID-19 as per their VA medical records. There is regular analysis done to ensure data quality. This includes weekly and monthly reports to identify any system-based issues. Additionally, we assess particular variables for completeness and determine what other VA data sources can be used to strengthen the quality. Other variables such as smoking status and burn pit exposure have been operationalized also to strengthen the analysis we do. There are three primary data sources which we predominantly use: the questionnaire, the clinical examination data, and VHA medical records. Some commonly used sections of the questionnaire, which we have used in our research, are based on deployments, including duration and exposures, self-reported health status, including physical limitations, and also self-reported diagnoses and reported symptoms have also been used. I will now be showing a few examples of these three data sources and how they've been applied in our research. In this study, we examined pulmonary care among veterans with an airborne hazard clinical exam. We used data from the registry, questionnaire, the clinical exam data, and also outside VHA medical records. We took a subcohort of registry participants who were enrolled in the VA healthcare system and had received airborne hazards clinical exam. Next, we identified veterans in this cohort who received primary and secondary pulmonary care. CPT procedure codes and clinic stop codes from VA medical records were used to identify both of these cohorts. An individual receiving primary pulmonary care was deemed with a recorded chest X-ray and/or pulmonary function test. A classification of secondary pulmonary care was identified as a recorded pulmonary consultation and/or a CT scan. I would like to note that only procedures done within 5 years prior to and after the airborne hazard exam were included in this analysis. Most of the participants obtained testing prior to an airborne hazard exam. We did match this data with information from our questionnaire. This included self-reported respiratory symptoms, such as wheezing, increased sputum, shortness of breath, and chronic cough, and also self-reported diagnoses, such as emphysema, chronic bronchitis, COPD, and asthma. After reviewing the self-reported diagnoses and symptoms data from the registry questionnaire, results consistently indicated that if a veteran reported symptoms or conditions on the questionnaire, they tended to be evaluated before the optional in-person exam. I understand that I'm providing a very general overview of this data, and for this study and also in the next few I'll be discussing. This is due to our time constraints. However, at the end of this presentation, you'll find citations for all the work which I'll be discussing today. Next, in this study, which was presented at the American Public Health Association's annual conference in 2020, we examined a subset of deployed service members who had exposure through duties during deployment. We relied on the registry questionnaire responses in this analysis and compared service members with and without a recorded occupational exposure to vapors, gas, dust, or fumes, which I'll be referring to as VGDF. Self-reported VGDF exposure was based on questions listed here on the left side of the slide, including were you in a convoy or other vehicle operations, performed refueling operations, performed aircraft, generator, or large engine maintenance, or performed construction-related activities. Participants who reported a non-military exposure to a dust, gas, smoke chemical vapors or fumes were excluded from this analysis. The self-reported diagnoses, which we looked at, included a yes response to asthma, chronic obstructive pulmonary disease, chronic bronchitis, and or emphysema. We saw that in this cohort, registry participants were exposed to VGTF at an increased odds of self-reporting chronic respiratory disease post-deployment. More research is needed on this topic. However, this does point out to specific occupational exposures which service members are exposed to during deployment. Our group was generally interested in rates of sleep-related disturbances amongst registry participants as a whole, as well as female participants individually. As a whole, we found that sleep-related disturbances were highly prevalent, including 40% of reporting sleep apnea in the questionnaire and over 80% reporting insomnia within the registry questionnaire. Focusing on more about sleep apnea, we found that 20% of female participants endorsed this condition and that the rates were higher among postmenopausal women. This knowledge is important, was important for preparatory research, and the findings were applied to a recent grant submission. As we've shown in previous examples, we utilize various data sources in our research and decided to examine the concordance between symptoms and conditions among these three modalities. We specifically looked at lower respiratory symptoms and respiratory conditions among the registry questionnaire, VA medical records, and also the clinical examination. Symptom information was pulled from the three modalities using the criteria shown here in the upper left. Based on the questionnaire, we use self-reported cough, wheezing, whistling, and sputum responses. For the clinical evaluation, we focused on chief concerns recorded during the examination. And when we're looking at the medical records, we used ICD-9 and 10 codes for cough, wheezing, and sputum. As for a disease, here on the right side, you can see that we used self-reported diagnosis of asthma, emphysema, chronic bronchitis, COPD, constrictive bronchiolitis, IPF, and other respiratory diseases in this analysis. For the evaluations, we looked at respiratory abnormalities and also used ICD-9 and 10 codes pulled from the medical records for the third modality. After testing concordance, we saw a consistent lack of agreement between lower respiratory symptoms and the presence of a lower respiratory condition across data sources. The concordance, still relatively low, but much stronger, was seen when comparing symptoms and disease within the same modality. This was true in all three scenarios. Lastly, we've recognized an increase in concerns regarding COVID-19 among registry participants. We examined cases of COVID-19 and patient care characteristics among deployed veterans who have participated in the registry and utilized VHA care. The data sources used were based on the questionnaire and also COVID analytical files with data from the VHA medical records. The data elements examined were demographic information, information on testing, hospitalization, and also recorded comorbidities. This brief summary, we saw that roughly 18.9% of participants were tested positive for COVID-19. And at least, and among the 1,872 cases of COVID-19 among participants we saw in the time period from March 2020 and November 2020, we saw that the characteristics reflected those of the broader VA population. Thank you very much for the time. And now I'd like to hand it off to Dr. Falvo to continue the rest of the presentation.
Thanks, Dr. Johnny. Let me see if I can switch screens here. And it looks like I'm going to have to ask you to please and thank you close yours, and then I'll load mine up. Load it.
1 minute, yes.
All right, thank you.
Okay.
Okay. Hopefully that's coming through for everybody. Okay, so I'm going to finish up the last 3 parts here to cover key collaborations, give some examples of our active research, and describe for the committee some of our future efforts. As Dr. Johnny mentioned earlier, we want to thank Dr. Savitz and the committee members for the invitation today and for the attention to those that joined in. So I think first and foremost, no single center can address these issues. And what we've realized is that we need key collaborators. Our center is very fortunate to have many excellent collaborators across VA, DoD, as well as academia. I want to take the opportunity to highlight 2, though, 2 key collaborations that directly involve the registry. So the first is what we refer to as the Ames Collaboration. Difficult acronym, but hopefully I'm going to come back to this and just say Ames. This involves principally a team of experts at the VA Center for Innovations in Quality, Effectiveness, and Safety, or IQEST for short, as well as the Baylor College of Medicine, and led by Dr. Drew Helmer. The IQEST team has extensive experience with big data analysis and implementation science. Our collaboration's overall purpose is to accelerate knowledge harvesting from the registry and related data, some of which you heard from Dr. Johnny, to improve the care and health of veterans with airborne hazards concerns. Now, much in the same way that the registry has 2 parts, both the self-assessment questionnaire as well as the clinical exam, our Ames collaboration has 2 parts as well. We have 2 broad foci that includes data science and analysis, as well as implementation. So I want to cover
Dr.
those.
Falvo, sorry to interrupt you. Just again, we can see the slides, but we can also see your notes.
Oh, I wasn't coming across very clear then.
Yeah, no, and it's fine, but again, make sure you don't have anything confidential in your notes. It has, yeah, I think you have to unshare, put it on slideshow, and then reshare or something along those lines.
Thanks for, this is like the spinach in the teeth, Dr. Savitz. So
well, it's not quite that. No, I would have spoken up sooner. I mean, we can all see the slides, but I'm sure that's not what you intended, to have us see all the notes too. So
how's that looking?
I'm not seeing anything yet other than you.
Okay, one more shot. And let's do screen share.
Slideshow, we should be all set then. There we go. Perfect. Thank you.
Hey, thank you for the heads up, sir. I appreciate it.
Sure.
Okay, so back to the specific aims of these of our Ames collaboration here. So the registry, as hopefully we'll kind of communicate throughout the presentation, serves and can serve a variety of different purposes that can provide value for both veterans and veteran stakeholders. This assumes, of course, that the data are clean, well organized, and efficient for reporting. Our data focus area targets these specific areas to facilitate and enhance current needs and requests, but also plans for future needs. Some examples include enriching operational reports and analytical data sets with clinical exam and related information. Additionally, we are working to establish and develop transparent processes on data use governance to promote knowledge sharing. We heard from Dr. Roll's group as the difficulties and challenges associated with that, and so that's certainly not a trivial effort. With respect to the registry's clinical exam, our implementation-specific aim seeks to identify best practices in registry clinical exam performance across VHA. The team has been evaluating a variety of different types of metrics to identify high-performing sites across the entire VHA. And they're now conducting interviews with those sites and those site leads to learn about those experiences, learn about their best practices. The overall goal for this implementation-specific aims is to then consolidate this information into best practice toolkits to be disseminated to the field, utilizing a well-established and transparent framework called REAIM. If I didn't point out already, I should point out that this Ames collaboration is only about 9 months old. So we started this in October of last year, but still the Houston-based team has made really impressive progress over this time, particularly as for many within the team, the registry was a brand new concept and something new to many of them. Fortunately, our collaborators have considerable related expertise that they've been able to leverage and very quick learners. I think many of them are on the call today, so a shout out to them and thank you for your attendance and help with these slides. In fact, they've already completed and or made considerable progress on many of the specific products that are listed here on these slides, both with respect to data as well as implementation. And just for example, we had a call yesterday and they were sharing and discussing a recent interview they had with a high-performing clinical exam site as a way for us to learn more about how those specific sites across VA are conducting exams efficiently and at great volume too. So in general, we believe the Ames collaboration will have impact in several areas. It'll help with improving the veterans' experience, number one, with the registry clinical exam, hopefully allow greater enterprise level accountability around these clinical exams, help improve scientific advances in the understanding of airborne hazards related issues, as well as enhance understanding of healthcare delivery related to military exposures and how to improve it. What I hope is clear from this Ames collaboration is the opportunity for research, which is a core kind of focus for our Center of Excellence. The second collaboration I wanted to spend just a few minutes to highlight is the post-deployment cardiopulmonary evaluation network. If you haven't been able to tell yet, we absolutely love acronyms around here. So I will do my best to avoid too much use of them, but we refer to this as the PDCN. And we seek to provide comprehensive specialty evaluations for veteran registry participants that have specific health concerns that I'll highlight in the subsequent slide. So our network currently includes 4 other sites in addition to our location here in New Jersey that's led by Dr. Aeneas Sotolongo. These sites are led by VA physician scientists with expertise in pulmonary and occupational medicine. So in your slide here, going from, well, west to east or left to right, we have site directors that include Dr. Mehrdad Arjamandi in San Francisco, Dr. Silpa Kreff from Denver, Dr. John Osterholzer from Ann Arbor, and Dr. Stella Hines in Baltimore. So the PDCN, our network, we have several goals, but our primary effort is around the focused clinical evaluation and study of veterans within the registry. Now, it's important to also kind of point out that, that our evaluation through the network, that's distinct from the evaluation, the typical registry clinical exam that Dr. Johnny was mentioning earlier. That's available, again, to all participants at their local VA or military medical centers. But the PDCN and our approach here, we start by reviewing data within the registry to identify veterans who are reporting shortness of breath or dyspnea, as well as reporting specific respiratory conditions. Now, those conditions may be very specific, like asthma, COPD, or constrictive bronchiolitis, but they could also be unknown conditions. The latter may reflect uncertainty in terminology and diagnoses post-deployment, such as the case we've heard many times before when symptoms appear disproportionate to testing, which we think very much underscores the need for a more comprehensive evaluation. After conducting initial eligibility screening, we contact veterans and invite them, if they're interested, to one of our PDCN sites for a standardized evaluation that often spans multiple days. In addition to providing veterans individualized expert care, our goal is, our larger goal is to learn from our collective experience across sites to hopefully inform best practices for standardized workups. Then that information we can then disseminate across the VA. We also hope that this infrastructure of these multiple sites will also facilitate opportunities for multi-site research that include but aren't limited to treatments. I wanted to take just a quick moment to highlight just a couple of key points about this core clinical evaluation that took several months for our team to develop. Foremost, the network is led by specialty experts in pulmonary and occupational medicine, who along with other multidisciplinary providers and clinicians address the concerns the veterans have and provide a very thorough examination. Central to our core clinical evaluation is comprehensive cardiopulmonary testing. Those include all of the traditional elements that you might expect, as well as some unique techniques such as forced oscillometry to evaluate distal airways that we found very helpful. In addition to supplementing their evaluation with their registry responses, we also re-ask some of the temporal questions. So for example, if a veteran completed a registry in 2015 and we evaluate them this year in 2021, we want to make sure that we've captured any difference from the time at which they've first completed the registry to the time of evaluation. We've also been very fortunate to work with the study chairs from VA's Cooperative Studies Program 595 to enhance our evaluation with their exposure assessment and deployment location approach. We include high resolution CT imaging and quantitative analysis on that. And then importantly, we look beyond the lungs as well. So those were the two key collaborations I wanted to highlight. Dr. Johnny also talked about some of our recent presentations at conferences, but I want to take the opportunity just a moment to highlight some of our active research as well. Now, as previously highlighted by this committee, we too are aware of research challenges with the registry. Three of the perhaps most important are the self-reported nature of exposures that are subject to recall bias. Though that doesn't diminish their importance, as self-report is extremely powerful, but we recognize it lacks objectivity. The phrase, you only know what you ask, certainly applies with survey questions, as we only have responses to the questions that were asked and completed. And perhaps most important with respect to bias is participation rate. This is a voluntary registry, therefore our ability to evaluate health effects may be associated with specific reported exposures, but that'll be predicated on the eligible individuals that chose to participate. Despite these challenges, there are a couple of ways at which we can create opportunities. So one is the possibility of evaluating different exposure metrics in comparison with those that are self-reported. Enhancing the questionnaire through the combination of clinical exam and medical record data. We've illustrated some of that previously. And then lastly, and I'll talk about this in a few slides, as a recruitment resource of potential individuals, potential motivated individuals who may want to engage in additional research studies. So let me highlight a few of those and how we're leveraging the registry here at our center. So in the next two slides, I want to describe how research questions can be developed and refined using the registry. As a national referral center, we see veterans with unique presentations, including exertional dyspnea, often of unknown etiology. Most endorse concerns regarding their airborne hazards and burn pits exposure. And they also frequently endorse exposure to blast events. Our clinicians question whether blast contributed uniquely to dyspnea and other respiratory symptoms. And then fortunately, we were able to address this question, and Drs. Helmer and Johnny analyzed registry data and subsequently found that self-reported blast exposure seemed to be independently associated with respiratory symptoms and exercise intolerance. So though these registry data supported that hypothesis, they of course require more rigorous assessment through clinical and focused epidemiologic studies. One of the first things that we were able to do is evaluate our own clinical data here at the center. And since we've provided cardiopulmonary services now to well over 600 deployed veterans, we could assess whether their blast exposure had any direct impact on their lung function. Some of these data we've presented at the American Thoracic Society at 2 prior conferences, which I won't go into great detail here, and references are towards the end of this presentation. But what we did see is it suggested that blast exposure, may in fact also have an impact on lung function parameters in addition to symptoms. And just a quick side note, as I'm sure several on the call are aware, recent work from National Jewish has also reported the very same thing, where they found in their study, those that were reporting more frequent blast exposure had greater injury to the distal airways. So it seems like there's several groups working on this topic. Now, with the registry self-report data combined with our center's objective lung function data, we're able then to use that information to develop a collaborative proposal with colleagues at Walter Reed Army Institute of Research, which we were fortunate that was recently awarded by the Congressionally Directed Medical Research Program. This study is now actively recruiting participants and to evaluate the impact of blast on health effects in a rigorous and systematic way. Now, as part of our recruitment for that blast study, we will use the registry to identify potential volunteers. Therefore, I hope what I've illustrated here is that you're seeing from study concept to recruitment, the registry has been integral to our success in evaluating the impact of blast exposure. We also recently obtained institutional approval for a survey-based study to learn more about veterans in the registry who were diagnosed with COVID-19. Dr. Johnny previously mentioned some of the demographic characteristics which we presented at an earlier conference. What we want to do is now reach out to those veterans directly and conduct this survey through a virtual manner to learn about their experience with COVID with the hope of generating preliminary data to support more focused research. We're particularly interested in understanding the so-called long COVID experience and potential risk factors. I want to conclude this brief talk with some comments about our short-term and longer-term plans that involve the registry. Now, as we're all adapting to a post-COVID world, we hope safely, we look forward to ramping up our in-person specialty evaluations across our network. So increasing that access is something we're keenly aware of and are happy to report that we're starting to do that currently. Our Ames collaboration is progressing swiftly to meet the goals that we've laid out previously. And we expect that over the next several months, we'll have learned more about best practices among some high-performing sites that we can communicate to the field. And in fact, later this fall, our center will be giving a webinar on the preliminary findings for providers. Didn't really have an opportunity to comment too much on our educational activities, but that is very central to all of our efforts here at the center. We see continued leveraging of the registry to support research as well as recruitment, and hope to continue conversations with interested investigators both in and outside of the VA. And then lastly, we look forward to implementing enhancements to the registry. Now, I put several of these on the slide here, and all those we were asked to comment specifically on the center's activities. Not all of these, of course, are directly related to our efforts, but in collaboration with our partners at Post-Deployment Health Services, some of which Dr. Schuping has highlighted before. But just to highlight a couple for the committee, you may have already seen a revision to the registry homepage and related content to provide veterans clearer communication. Many of these changes, importantly, were in response to direct veteran feedback. We also want to improve the provider user experience. And again, this is based on feedback from the field and revising reports that are available in the clinical portal to capture what the provider is most interested in finding out. And then some active efforts that are underway include working on modifications to the questionnaire to allow participants to update deployment segments after their initial entry. So if they completed the registry, subsequently deployed, making sure that they come back and then enter that deployment. Other efforts include more accurately matching updated address and location information to ensure that our facility level and other metrics are most accurate. And working to secure a contract to have external survey experts advise on the reorganization and content of potential registry questions. So I hope what Dr. Johnny and I have been able to communicate to the committee is some of our center's major efforts around the registry. I think, or I hope what you've seen is that our areas of emphasis are certainly overlapping across clinical care, research, as well as implementation into the field and how we disseminate this across. No, though not specifically stated here, but across all areas, information routinely is made available to senior VA leadership and associated committees like this today to inform decision-making. Our center was established 2 years ago with a vision of having broad impact on veterans' health and their care. And the registry is one key area for our center. And it's our hope that we are utilizing and improving this resource to best serve veterans. I would be remiss if I didn't acknowledge all of the folks that are involved here. There are far too many to leave out. So I will keep this very general and just to acknowledge Dr. Shuping and her colleagues at Post-Deployment Health Services, our center's co-director, Dr. Sotolongo, and our team at the New Jersey Risk, led by Dr. Helena Chandler. I also wanted to specifically thank Dr. Helmer and our colleagues from the Ames Collaboration, our site directors, and their respective teams within the Post-Deployment Cardiopulmonary Evaluation Network. With that, I think Dr. Johnny and I would be happy to take any questions.
Great. Thank you very much, both of you, Dr. Johnny and Falvo. Let's open it up to the committee, and you can turn your cameras on, and I will try to watch for hands, but if I don't see your hand and it's up, or just go ahead and speak and we'll manage it that way. But we've got 10 minutes or so for questions.
Well, this is John Balms. I'll jump
Thanks,
in.
John. Please.
Thank you, Drs. Johnny and Falvo, for that presentation. You know, one question I have is how often participants in the registry actually, sorry, that's my dog in the background. I mean, how often the folks that elect to have a clinical exam in the VA system, how often is that clinical exam used to provide improved care within the VA system? You know, I've heard anecdotally that that clinical examination data isn't often used by clinicians. That's anecdotal. Do you have any information about how often the clinical exam data is actually, you know, used by primary care providers and specialty care providers within the VA system?
Thank you for your question. So it's difficult to say exactly, you know, how many primary care providers, suggest follow-up care after, after the clinical examination. However, we can say that a majority of individuals who receive an airborne hazards evaluation do continue to have some sort of care within the VA system. I cannot right now specify if it's pulmonary care or primary care or the type of care, but a majority do continue to receive VA care.
Well, I understand that. You know, But the specific question, which I probably didn't articulate well with while my dog was barking, what is, do we know anything about care related to the information generated by the clinical exam? I understand that many of them will continue to have VA care, but are they being, is the clinical exam data actually being used to drive that care in any way? I don't know if you have data about that, but that's an important question, for the committee.
That is an important question and an excellent one, Dr. Baums. And I think you're touching on something that has been brought up in our that Ames collaboration. So we want to really kind of get into the data to identify, how well is this being used? Is it being uptake by other providers as intended? And right now that we don't have an answer for you, but that's something that's at the top of the list.
If I could extend that just a little bit, I think, we're talking mainly about people who have received an exam, and obviously there's presumably no place better in the country to go for exams than your program. But is there any sort of pathway by which your knowledge of what's clinically useful for this population shared so that when they go to another VA provider who may not have any environmental medicine expertise, or someone outside the VA, just their family physician, is there any sort of pathway from what you learn to guiding the care, something that, let's say, registry participants could bring when they go to their family physician, or something for the non-expert care providers that comes out of your center?
Well, just from a general perspective, that point is well taken, because we need to communicate both, not only just to the VA providers, but those that are outside of the VA that are seeing veterans as well. We try to do that a few ways. So one is which we try to share the information as we learn it to different forums, whether that's conferences, publications, what have it. That's critical. We worked with the American Thoracic Society to generate a patient education series, a fact sheet on burn pits. And provided within there links to some really critical resources where folks in and out of the VA could attend some of our trainings in person on the web. So developing that education and getting that out, that's critical. I don't think I addressed specifically your question about the veteran that kind of leaves after the exam. What are they going to take away with them, and what potentially could they bring to a provider?
Well, and I was actually thinking more, though, again, for the vast majority of registry participants who don't come to you for an exam, if you have any way you can provide advice or any pathway that leads based on what you've learned to say, when you get care, or you should be, or sort of advice. I wasn't sure if there's a part of that feedback loop, or if that's something that you've not really gotten into yet, back to the the tens of thousands of registry participants you don't see.
Sure. You're right, communicating that out to the field, but more importantly, the tens of thousands that we're not going to interact with. We certainly thought about strategies on how best to do that, some of which I mentioned, but that does require additional attention and resources. Yeah. That's important.
Understood. Thank you. Other committee questions? We have a few more minutes here. Again, just speak up if you.
This is Fran Murphy. I have two follow-up questions, if I could. Related to some of the questions you've had about the use of the registry questionnaire and the registry exam, you obviously have the post-deployment, the PDCEN, and so from those exams who's being referred. When you look back at the use of the registry questionnaire in those highly selected patients, do you see any patterns? Is the registry actually driving better clinical care? What do you see from that aspect?
Thanks for the question, Dr. Murphy. Specific to the network, so that is not necessarily a referral program, but actually we use the registry and we approach it in an algorithmic way to identify veterans that then we reach out to see if we could provide them care and then invite them.
So they're not referred by primary care or specialty care providers?
Not typically, no, ma'am.
Okay.
That said, I will say that I think our site directors have certainly gotten attention within the respective medical centers and are often asked a lot of these questions. But we don't, because we've started this program, right in the middle of COVID. And so we don't have a good volume to point towards right now.
Mhm.
But I think that's the information we need to glean, like how effective is that registry in enhancing that care? It's a good point.
Okay. A second question on a slightly different topic. I was interested in the fact that you said you're trying to improve the patient experience. And one of the things that I wondered about in some of your analysis of the registry participants' experience, have you done patient satisfaction surveys? And is there a difference between patients who were exposed to burn pits who participated in the registry versus those who did not in their satisfaction with care?
Ooh, that's an excellent question. Dr. Johnny, are you familiar with, I am not.
I know there have been some focus groups. Maybe I think Dr. Shuping would have more information on that. But PDHS has done some focus groups among registry participants. But beyond that, no, we have nothing that I know of.
Okay. I know VA has a pretty robust patient satisfaction survey that they do, and they select individuals who have gone to certain clinics or primary care or inpatient programs. It might be a future resource for you.
That's a great point. On a smaller scale within the network, that's built in, and we do assessments from that, pointing towards many of those same resources, something our center's done for a long time. But on a large scale for the entire registry, that's not something that I'm familiar with currently. Thank you.
Good. I think we're about out of time.
Can I ask one last question?
One quick. You got the last one, John. Go ahead.
So I realized that the pandemic limited inpatient or in-person evaluations, but in terms of the post-deployment cardiopulmonary exposure network, PDN, how many folks have been evaluated so far? Roughly speaking.
Sure. I'm going to put that number, Dr. Baums, at probably less than 50 over that time. We've probably chart reviewed. I presented some of this at ATS a few weeks ago, so the numbers I don't have exactly.
Actually heard it at ATS, but I couldn't remember the.
Oh, okay. So we've conducted the screening about 450 veterans. We've been in touch with about 100, and I would say less than 50 have completed some level of evaluation. And that has been regional differences. Our facility, we're fortunate to be up and running, but others have more conservative protocols currently.
Thank you.
Thank you, sir.
Good. Well, I think we're going to close this part of the meeting. And again, I just want to thank all the speakers for really being quite responsive to the committee's questions and being so generous in taking the time and sharing their abundant knowledge with us, which again, I'm sure will be helpful as we work on our report. So we will break now. The committee will reconvene in closed session at about 3:45 Eastern time. Again, thanks everybody, and thanks to the audience for your interest as well.